How's it going, guys? We have a past level question for internal medicine, family surgery, 2CK for saying for step one. I'll tell you exactly the high yield points you need to know, not waste our fucking time. 52-year-old man, BMI 35, vitals normal, physical exam shows 3+ pulses in the upper lower extremities. 2 to 4+ is normal. Okay, so 3 to 4+ considered brisk, but in general, patients can have 2 to 4+ considered normal. 1+ or 0 would be deficient on USMLE. So our point so far is that our peripheral pulses are fine. Current medication is lisinopril metformin, so obviously he has type 2 diabetes on metformin here, and then lisinopril, the implication could be he has either high blood pressure, proteinuria, elevated creatinine or renin. So those are the indications for giving ACE or ARB in the setting of type 2 diabetes, and type 1 for that matter. He has smoked 1 pack of cigarettes daily for past 20 years. So we've got this image. I'll talk about this as we move through the question. Which the following next best step in diagnosis? Choice A, ankle brachial indices, wrong fucking answer. This is what we do for peripheral vascular disease. Now, even though we could articulate the notion that because he has diabetes plus or minus hypertension, that he would have a degree of atherosclerotic disease, and you say, well, he could have peripheral vascular disease, I agree with you, but it's clearly not the focus of our question because our peripheral pulses are normal. If the USMLE wants to make arterial disease the focus, they will tell you that the peripheral pulses are diminished. They can also give you a presentation such as intermittent claudication, okay? Now, high yield points that you need to know. Number one, and this is exceedingly important for 2CK, ankle brachial indices are the first line, or the first thing we do for suspected arterial disease. So for example, if they give you intermittent claudication, choose ABIs first. Don't choose arteriography. Don't choose solostazole. You're going to choose ABIs. You're comparing the blood pressure in the leg to the blood pressure in the arms. If the ratio is under 0.9, that means we have atherosclerosis causing attenuated pulses distally, and that's arterial disease. And then the next best step after the ABIs are low, if they say it in the last line of the question, is going to be a stress test, an exercise stress test if it's listed. If it's not listed, you're going to go to recommended exercise / walking program. They can write it as prescribe a walking program, prescribe an exercise program. Do not choose solostazole. It's the wrong fucking answer 14 out of 15 times, okay? If they force you to choose a medication, you can choose solostazole. It's a phosphodiesterase inhibitor that has utility in some patients with peripheral vascular disease, but they want ABIs first, followed by exercise stress test to determine exercise tolerance. If it's listed, if it's not, go to walking program. And then in 1 out of 15 times, if the patient's already on a walking program, they force you to choose an agent, you're going to choose solostazole. Choice A, wrong fucking answer. Choice B, chest x-ray, wrong fucking answer. What they could do in the setting of showing you an image of the feet or hands would be hypertrophic osteoarthropathy. They show you clubbing. They tell you the patient has joint pain. They tell you the patient's a smoker. And you just need to know that that's lung cancer causing hypertrophic osteoarthropathy. Wrong fucking answer. Choice C, electromyography, nerve conduction studies, wrong fucking answer. So this is a very generic answer choice that if you Google it, it could be used for 100 different things. It's to my observation across 2CK and BME forms that this can be done for polymyositis, can be done for carpal tunnel syndrome, can be done for Guillain-Barré. In this case, wrong fucking answer. Choice D, fungal culture, wrong fucking answer. So through this and be an asshole. I mean, students don't know what's going on, choose weird shit. So you could be aware that candidal infections can be erythematous. If they give you woman BMI 55, type 2 diabetic, and they say she's got a large erythematous moist plaque under one of her breasts, that's cutaneous candida. They want dysglycemia as the most important risk factor. And even in that case, you're not going to do a fungal culture. Just garbage answer choice. Wrong fucking answer. Choice the ultrasound correct answer. So this is venous disease. We're going to do duplex ultrasonography of the calves. Our image is showing us stasis dermatitis, aka post-phlebitic syndrome, aka brawny edema. Okay, so this is hemosiderin deposition. We've got increased venous hydrostatic pressure with extravasation of that hemosiderin into the interstitium. All right, now this image here, they want you to know this. I mean, if we were to see not just this, but a venous ulcer, they show you a large slothy ulcer at the medial malleolus, also very high yield. In contrast, arterial disease, they can show you not the brawny edema, but they'll show you punched out smaller ulcers on the tops, bottoms of the feet, on the toes. Okay, so This is venous insufficiency as our diagnosis. That's an umbrella term that can refer to just general valvular incompetence. No one specific etiology, familial propensity, but patients who are overweight, of course, risk factor, but they get the hemosiderin deposition here. They need not have varicosities. That's also under the envelope of venous insufficiency. Okay, if they just give you varicose veins in a patient, but the patient doesn't have any type of hemosiderin deposition, you're also going to do ultrasonography. Okay, so the next best step in management for this patient is going to be compression stockings. Now, that's going to be the answer 9 out of 10 times. So we already do the ultrasound, venous disease, compression stockings. 1 out of 10 times, if they give you this same patient and they say he's got a tender slash painful, warm, palpable cord at the ankle that may or may not track up to the knee, that's superficial thrombophlebitis, you're going to do subcutaneous enoxaparin, it's heparin, because you have to treat an active clot. Superficial thrombophlebitis is essentially the same thing as a DVT, just in a superficial vein. So for a DVT, likewise, you're going to do heparin as the next best step, not compression stockings. But the vast majority of the time, you're going to have compression stockings as the next best step with ultrasound for venous insufficiency. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.